The policy I'm proposing to change is the Child Abuse Prevention and Treatment Act, CAPTA, a federal statute governing child protection standards and funding across the United States. CAPTA's goal is to support states, territories, and tribal organizations in preventing, identifying, and responding to child abuse and neglect. While CAPTA includes multiple funding mechanisms, the most prevention-focused component is Title II Community-Based Child Abuse Prevention (CBCAP) grants. These grants fund community-driven programs that strengthen families, address material needs, and reduce the conditions that contribute to maltreatment. Lane et al. 2025. The change I want to see is a significant shift in CAPTA's orientation towards Title II by increasing federal appropriations for CBCAP and embedding anti-poverty, culturally responsive prevention strategies directly in CAPTA's statutory language. This would move CAPTA away from its historic emphasis on reporting and surveillance towards an upstream public health-oriented system that distinguishes poverty from maltreatment and invests in early supports. NASW 2024, Lane et al. 2025. This is a redistributive shift because it reallocates federal dollars towards prevention services targeting communities most affected by structural inequities. Following Lowry's framework, it is also expansionary because it increases federal capacity for prevention without removing existing protections and incorporates regulatory elements such as cultural and linguistic competence requirements for grant eligibility. Lane et al. 2025. Enhancing Title II will strengthen the upstream health impacts of child welfare policy by expanding access to home visiting programs, parenting support, child care, concrete goods, and culturally grounded services. These interventions reduce unnecessary investigations rooted in poverty and advance health equity, aligning with NASW's mental health and anti-racism standards. NASW 2024, Lane et al. 2025. Research on policy advocacy also notes that sustainable improvements come from building capital, data relationships, and political leverage to reshape how systems define family needs. Lyons et al. 2011. This reform directly supports families who face systemic barriers, low-income households, communities of color, immigrants, and rural families. By expanding access to locally tailored prevention services, community-based, culturally-specific organizations have proven effective in providing rapid, rights-affirming support, as documented in response networks built by the Washtenaw Interfaith Coalition for Immigrant Rights, Sanders et al. 2013. Strengthening CBCAP would help scale that kind of trusted infrastructure. The second policy I propose to change is the Federal Violence Against Women Act, VAWA, which provides funding and legal protections for survivors of domestic violence and sexual assault, dating violence, and stalking. Although VAWA funds many critical services, it lacks a dedicated federal stream for long-term trauma treatment, and culturally specific programs remain underfunded relative to need. From a health policy perspective, untreated complex trauma is a chronic condition that generates long-term medical, behavioral, and social costs. The change I want to see is the creation of a VAWA trauma recovery program within the Office on Violence Against Women, OVW, that would fund long-term therapy for complex PTSD and battered women syndrome, support culturally grounded healing practices, tribal, faith-based, immigrant-led, and community-defined, and require grantees to demonstrate cultural and linguistic competence with priority for African American, Indigenous, LGBTQ+, immigrant, disabled, and rural survivors. This reform is expansionary because it introduces a new federal grant program, distributive because it creates a new funding stream, and redistributive because it targets historically under-resourced communities. It also incorporates regulatory conditions related to culturally responsive and trauma-informed care. Lane et al. 2025, NASW 2024. A dedicated trauma recovery stream addresses a major gap in VAWA. Many survivors require extended specialized treatment that crisis services cannot provide. Long-term stabilization has downstream benefits for health, housing stability, employment, parenting, and court participation. Outcomes aligned with contemporary health policy priorities around integrated behavioral health, Lane et al. 2025. Requiring culturally responsive care further aligns with NASW standards for equitable mental health practice, NASW 2024. This proposal specifically strengthens access for marginalized survivors by investing in community-based, culturally specific, and survivor-led organizations. Such groups are often the most trusted and most effective at meeting immediate and long-term needs, as seen in Immigrant Rights Coalition, whose grassroots networks enabled rapid, humane, and rights-oriented responses. Sanders et al. 2013. Political Advocacy Scholarship also highlights that durable policy improvements emerge from coalitions that blend lived experience with strategic legislative work. Lane and Pritzker, 2018, Lyons et al. 2011. Both policy reforms, reorienting CAPTA with CBCAP and creating a VAWA trauma recovery program, are consistent with health policy evidence showing that prevention, early intervention, and long-term healing reduce inequities and improve population health. Lane et al. 2025. They also operationalize NASW's calls for accessible, culturally responsive, trauma-informed mental health care, NASW 2024. By centering community-defined solutions, investing in prevention, and expanding long-term recovery supports, these reforms move federal policy beyond crisis response